Hello everyone, this is Michael McGinley, and today I'm presenting a case on balloon uncrossable lesions and the use of new torqueable atherectomy wires. Our patient is a 71-year-old man. He has history of hypertension, tobacco use. He presented with non-STEMI and very low EF of 20%. His coronary angiography showed RCA-CTO, mid-LAD CTO, and OM1 CTO. So he was in cardiogenic shock. Intra-aortic balloon pump was placed and was weaned off after a few days. MRI was performed, showed viable myocardium, and he was referred for high-risk PCI. So this is his angiography, and a lot of overlap here, but it shows the LAD CTO here with late filling in the distal LAD here. So given his high risk, we performed right heart cath to get his baseline hemodynamics. His PA pressure, mean PA pressure was around 29, but his wedge was 26. So we decided that we would use hemodynamic support with Impella. So we accessed the left femoral artery, but we had difficulty advancing. And with angiography, it showed severe left iliac disease. So we decided to place in a stent to help advancing the Impella sheath. So we used an ICAST covered stent, 8 by 38 millimeters, and after that we could easily advance the Impella sheath. Impella was placed and flow started at 3.5 liters per minute. And again, we did angiography that showed severe calcified LAD disease. So we started with a workhorse guide wire, a Xi'an blue, that luckily crossed that severely diseased segment into the distal diagonal branch. We then tried to advance a Cardiovascular microcatheter over the wire, but the Cardiovascular microcatheter would not cross. So for balloon or microcatheter uncrossable lesions, this is the algorithm. We start by using smaller and smaller balloons. We might rupture the balloon in the vessel, which is called granuloplasty. We use different microcatheters like lower profile or torqueable microcatheters, and then we might use wire cutting or puncture. Using improving support using guide extension anchor balloon strategies are also helpful. And in the algorithm, if this all did not work, we proceed with laser atherectomy or conventional atherectomy. And finally, we can use subintimal techniques and retrograde techniques. So in our case, we tried crossing with a Sapphire Pro 10 millimeter balloon, which is very low profile, but this did not help. And then we tried to use a torqueable microcatheter Turnpike LP and low profile microcatheter, which is a Caravel, and this all did not cross. So what we decided to do is to proceed with atherectomy using the new CSI Viper wire advance with flex tip, which is very torqueable, to primary wire the lesion and then use atherectomy. And here we can see the wire is tracking the Xi'an blue wire into the distal LAD. We then perform multiple runs of CSI atherectomy, and at this point, using Turnpike LP microcatheter, it could easily cross distally. However, we noticed that the PA pressure has increased to 60, as you see here, and fortunately, we had the Impella in place to support the patient. We did angiography, and we noticed that we had sluggish flow in the proximal diagonal branch, which is probably the reason why the hemodynamics got worse. So we recrossed the diagonal branch with a Xi'an black guide wire, used the Turnpike LP exchange for a Xi'an blue, and dilated with a 2.0 balloon. We then did multiple balloon inflations in the LAD with the 2.0, 2.5, and 3.0 balloons. In In the middle, stent delivery attempts failed, so we performed more balloon inflations, and then we decided to use a more deliverable stent, so we could easily deliver a 25 by 38 Synergy DES inflated adequately in the mid-LAD. We then used the 30 by 18 Science DES proximally. And this was our final result. So the impella was left in place as the PA pressure was high. Patient started on nitroprusside, both PA pressure and blood pressure improved. And then the impella was removed the next day uneventfully. So conclusions, in case of balloon uncrossable lesions, when everything fails, the Viper wire with flex tip, which is a torqueable guide wire, can be used to primarily wire the lesions and then use orbital atherectomy to facilitate crossing afterwards. Number two, using hemodynamic support is important in high-risk PCI, especially in patients with low EF, multivessel disease, and high filling pressures. Side branch loss can lead to worsening hemodynamics, and this has to be promptly identified so it can be treated by recrossing and ballooning of the side branch. And finally, iliac stenting can be helpful to aid advancing impella in patients with severe iliac disease. Thank you so much.